Okay, so this is video number 5 in the 6-part video series on hemodynamics and circulatory shock. And in this video, we're going to be talking about obstructive shock. And my name is Lexi Graham, and let's get started. So obstructive shock is just how it sounds. This is the best picture I could find to represent obstructive shock. This is an obstruction, not letting blood get to where it needs to go, inhibiting oxygen to getting to all the parts, the vital organs and things that needs for you to survive. So this would be in like a pneumothorax, a pulmonary embolism, or a cardiac tamponade. And in this video, we're going to be talking, referring mostly to cardiac tamponade in this video. So common physical exam findings would be dyspnea, tachycardia, tachypnea, elevated jugular venous pressure, chest pressure, pulsus paradoxus, increased urinary or decreased urinary output, confusion, dysphoria, and then cold and clammy extremities due to hypoperfusion. So imaging studies, you can do chest radiograph. These findings may show cardiomegaly, pericardial calcifications, or evidence of chest wall trauma. A bowed catheter sign on chest radiograph in children after central venous catheter insertion may be suggestive of a cardiac tamponade. CT scans, compression of the coronary sinus observed through CT scanning can show early markers for cardiac tamponade in up to 46% of patients. Though echocardiography remains the best primary modality for detection and assessment of cardiac tamponade, this can still indicate that as well. MRI, this can provide a better structural definition of the pericardium and detect effusions as inconspicuous as 3 milliliters with very high sensitivity. ECG will also show sinus tachycardia, low voltage QRS complexes, electrical ultrasounds, also observed during supraventricular tachycardia and ventricular tachycardia, and then PR segment depression. And these are the videos. This shows the cardiomegaly, the compression on the coronary sinus, and then the MRI, and then the ECG. And then we'll go to the next one. So hemodynamic monitoring, you're going to be using that Swan scan catheter again. The cardiac output will be low, the CVP will be elevated, and the pulmonary capillary wedge pressure may be elevated depending on severity. An elevated right atrial pressure is also a hallmark finding in cardiac tamponade, and as this is often the first chamber that will be affected by the pericardial compression. So medication options, dobutamine can be used. This is an inotropic agent which can improve the cardiac output. Beta-1 receptor agents can be used to increase stroke volume and cardiac output. And then IV fluids and vasopressors can be used temporarily, but invasive approaches such as percutaneous or surgical pericardiocentesis is the standard of care. So you're gonna want to remove that fluid. Is basically one of the first things you're going to want to do. ABG anomalies typically shows respiratory acidosis due to the decreased cardiac output, which leads to hyperventilation. But in severe cases, a metabolic acidosis can also develop due to the hypoxemia from poor blood flow. Mechanical ventilation. You're going to aim to minimize positive pressure ventilation, as this can worsen the condition by further reducing venous return, cardiac output. If necessary, if you have to use mechanical ventilation, you want to use low tidal volumes and minimal PEEP to limit the impact of the hemodynamics. And you'll want to consider doing that pericardiocentesis before you intubate, because if there's already a lot of pressure on the heart, and you're going to want to get all that fluid off and all that pressure the fluid's causing first before you add more pressure. Concerns, like I just stated just a second ago, an increase in intrathoracic pressure that will reduce the venous return, ventricular filling, and cardiac output. Since there's already an increase in pressure due to the fluid around the heart, these patients will already have hemodynamic concerns. And like I said, it is important to consider draining the fluid before you intubate this patient. And then, so in summary, how is it presenting? We're going to see dyspnea, tachycardia, tachypnea, the elevated jugular venous pressure, cold and clammy. They'll have dysphoria, confusion, pulsus paradoxus, chest pressure, or a decrease in urinary output. The imaging tools we can use to diagnose this are chest radiograph, CT, MRI, and ECG. And then the hemodynamics that we're going to be looking at are the low cardiac output, elevated CVP, and the elevated PCWP, depending on the severity. You're also going to want to be looking at the elevated right atrial pressure because this is most important in cardiac tamponade. And then with the medications, you can the dobutamine, the beta-1 receptor, and IV fluids and vasopressors. And you're also going to want to be doing that pericardiocentesis to get that fluid off. And then how we can enhance their oxygenation goals or without making them worse. So you're going to do the low tidal volume. If you have to use mechanical ventilation, the low tidal volume and minimal PEEP. But wanting to do the pericardiocentesis before intubating because we want to get that pressure off their heart and lungs or their heart before adding more pressure to them, and because we don't want to increase more the intrathoracic pressure because this could decrease ventricular filling and decrease venous return. So with that being said, that's all we have for this video, and thank you for watching.